Good evening everyone. Today we'll be discussing about interpretation of a liver function test. We see a lot of patterns here coming into the liver function test. We see ALT elevation, AST elevation, how is globulins and how is albumin, how is INR, and also how is ALP and bilirubin obviously. So mainly we look at when we are interpreting the liver function test, we'll look into how is the OTPT, that is AST and ALT, and also next we look into the ALP and bilirubin levels mainly. So how do you interpret this test? So let's say first you understand what are the functions of liver. So ALT and AST are mainly the enzymes which are like AST is generated in the liver, heart, myocardium, heart and muscle also. Whereas ALT is more specific. AST is present in many other organs, but ALT is more specific to the liver. Coming to the ALP, ALP can be present in like bone, intestine is there, it's there in the placenta, it's there in the liver, so it's present in the many other tissues also. But there are like bilirubin is mainly product of liver, but it can be based on the what kind of bilirubin pattern is there, whether conjugated are there, unconjugated is there, whether mixed is there. You can tell what is the cause of hyperbilirubinemia. And there are other tests also which are useful like gamma glutyl transferase. So if ALP is elevated, so to tell whether it is liver specific or not, we can use a GGT as a surrogate marker. If GGT and ALP both are elevated, then maybe it is a liver might be the cause of ALP, because liver specific ALP is not available in the outside labs. So we use GGT as a surrogate marker to tell whether it is ALP is coming from the liver or not. So coming into the INR and coming to the albumin. So albumin is tells about synthetic function of the liver. There are various functions of the liver. One is synthesis, like it synthesis the clotting factors like 2, 7, 9, 10, and also albumin. So in the long term, any chronic liver disease or any sometimes an acute infection also, because the albumin is a negative marker, so they can be decreased. So it will tell about the synthetic function of the liver. So other than infection, let's say albumin is decreased, and sometimes it tells you that synthetic function of the liver, especially in the chronic liver disease, because albumin is a long half-life, like around 21 days or something it will be there. So if that is low, albumin per se is low, if there is no other cause of acute infection or something, maybe you can think as a chronic liver disease or something. Even INR is deranged in the case because the decreased synthesis of 2, 7, 9, 10 and all. So these are the various functions. So we'll go into the case based scenario. This is a brief introduction of what are the LFTs that are present. So first case, a 45-year-old known case of alcoholic presented with the complaints of jaundice, and an evaluation ultrasound has shown to found grade 2 fatty liver, and AST is 196 and ALT is 94, and bilirubin is 8 milligrams per deciliter. So this is a 45-year-old male with known alcoholic with complaints of jaundice. So he has jaundice and also has ultrasound showed grade 2 fatty liver. So his enzyme elevation is AST is 196, ALT is 94, and bilirubin is 8. So what is the interpretation of this value? So he's a known alcoholic. There is significant alcoholic history. You should always ask how much amount of alcohol is there. Anything more than 14 units per week in male and 7 units per week in the female is significant. So he's complaining of ultrasound showed fatty to liver. There is enzyme pattern of AST more than ALT. So any AST of more than ALT, generally ALT will be more than AST in the case of liver enzyme elevation in most of the liver conditions. But AST more than ALT, there are very few conditions where AST will be more than ALT. One is cirrhosis of liver, the next is alcohol related disease. So in the case of alcoholic hepatitis, what happens is because of the deficiency of pyridoxine, so AST and ALT elevation pattern will be altered. So any liver enzyme elevation, AST more than ALT, ruling out CLD. Why CLD, AST more than ALT? Because AST is generated in many other organs, but ALT is specifically generated in liver. In the case of chronic liver disease, the liver cells are already damaged, so there is no enzyme generation per se in the liver. So most of the elevation is coming from the other organs per se, and also the elevation is generally usually less than 2 to 3 times per norm above the normal limit. So coming back to this case, here AST is more than ALT. So any AST more than ALT for more than 2 times is suggestive of alcoholic liver disease. If it is more than 3 times, the ratio AST to ALT ratio is more than 3 times, is suggestive of is definitely an alcoholic liver disease. So this might be a case of alcoholic liver disease with alcoholic. So if the enzyme pattern is not, this might be a case of alcoholic fatty liver disease. If enzyme is also elevated, it's alcoholic steatohepatitis, because enzymes there is inflammation is there. Alcoholic steatohepatitis is a possibility. So here the bilirubin elevation is also there. So coming into the bilirubin elevation, generally bilirubin is elevated in many causes like hepatocellular causes, obstructive causes, prehepatic causes. Prehepatic causes generally find in the case of hemolytic anemias, or mostly you'll find in those cases where indirect bilirubin is predominant, but generally the bilirubin elevation is usually not more than 6. So in the case of hemolytic anemia, generally if it is a autoimmune hemolytic anemia, it is usually less than 6. If it is a B12 deficiency, it is usually less than 3. So that is here 8 is high, very high. So in so that might be case of hepatocellular or obstructive jaundice. So how it is hepatocellular obstructive? So hepatocellular, this might be like hepatocellular obstructive. How you differentiate? One is in case of hepatocellular, enzyme elevation is more, AST ALT elevation is more. Whereas in the case of obstructive jaundice, the ALP elevation is more. AST ALT elevation will be there, but obstructive jaundice ALP elevation will be little more. Here they didn't mention about the ALP elevation, but per se alcoholic hepatitis can also cause hepatocellular jaundice, that can be bilirubin elevation. So that might be a cause of alcoholic hepatitis. This might be a case of alcoholic steatohepatitis. How do you differentiate hepatocellular and obstructive jaundice? We'll discuss in the later case-based scenario. But here, AST more than ALT, two possibilities. Alcoholic liver disease and cirrhosis of liver is the two possibilities. Here, alcoholic liver steatohepatitis is a possibility. So you treat them with you abstain the alcohol per se. You advise acetylmethionine and also you advise thiamine along with supplementation. You supplement other micronutrient deficiency also, and you monitor the alcoholic, like you can do the discriminant function score, discriminant functions, whether discriminant function score, and if it is more than 32, you can try steroids also like prednisolone or pentoxifylline can be tried if a discriminant function score is more than 32. And you can put them, like generally prednisolone will only decrease the short term mortality, not long term mortality. So if it is more, if you are starting steroids, you start at 40 mg for next 28 days. But to continue steroids or not, because they have a risk of infection also when you start the steroids and all. So whether to continue with steroids or whether to stop steroids at some time, it is based on Lilly score. So you do a Lilly scoring in the patient. If Lilly scoring shows the improvement with steroids, you can continue the steroid. What is Lilly scoring? You read about Lilly scoring after starting, after starting steroids. If discriminant function score is more than 32, after 1 week of starting steroids, you do Lilly scoring. If Lilly scoring is showing the improving trend in the case of after starting steroids, you can continue the steroids. If there is no improvement per se, there is 0.45 cutoff. Based on that, you can decide whether to continue steroids or not. So based on Lilly scores, you decide whether to continue steroids or to stop the steroids based on the benefit and all. So always in this is the case of alcoholic steatohepatitis, you do discriminant function scoring. You can start steroid for the short term benefit, and after 1 week you do Lilly scoring, and based on that you will decide whether to continue steroids or not. Case 2. A 28-year-old man who stays in hostel presented with the complaints of malaise, generalized weakness, and admitted in hospital, and he was found to have jaundice, and LFT pattern showed ALT 150 and AST is 248, and bilirubin is 12 milligrams per deciliter. So what is this case? So he is a 28-year-old female. He stays in a hostel. So he has malaise and generalized. So always in the case of viral hepatitis or any viral fever, the classical history of any viral fever per se is the presence of prodromal symptoms. So what are the prodromal symptoms? They'll have nausea, they have generalized weakness, they have fatigue, they have muscle pains. So these are the classical symptoms when the patient comes with a viral fever or viral hepatitis, whatever it is. So these are classical prodromal symptoms that are present. They are not present in other hepatitis patients. So if they are presenting with some malaise, some fatigue, some nausea-like symptoms, some body pain, some muscle aches, so always think of viral hepatitis. So the picture per se, malaise, generalized weakness, is suggestive of viral hepatitis. But let's look at the enzyme pattern. So he is having jaundice and bilirubin is 12. Okay, bilirubin is 12. In the case of viral and alcoholic hepatitis, you will have some sort of jaundice because of the congestion that is there. That will cause intrahepatic cholestasis because it decreases the bile, because bile canal goes through the hepatocyte cells. Because of some congestion, because of the hepatitis pattern, there will be congestion that causes hepatocellular jaundice pattern. So that bilirubin isolation is possible. But ALT is 150 and AST is 248. So ALT is 150, AST 140. Generally in the case of viral hepatitis, you expect ALT to be more than AST. But here ALT is less and AST is more. So generally ALT is usually more than AST in the most cases of the cases, but AST more than ALT, I told you two conditions, cirrhosis of liver and alcoholic hepatitis. So in this patient, maybe a patient is an alcoholic person. You should go back and ask for the history of any alcoholism is there. So if alcoholism is there, maybe the enzyme pattern will be all. In any hepatitis like viral hepatitis, Wilson's disease, or ischemic hepatitis, congestive hepatopathy, if the enzyme pattern is not following the trend which you expect it to be, always check for the alcoholic history, because in the background alcoholic history, if something is occurring, so alcoholic pattern will be followed, because coenzyme the pyridoxine deficiency will always be existing in those patients. So maybe this patient is a case of viral hepatitis in the background of alcoholic liver disease. That is why enzyme pattern is not following the trend of viral hepatitis and following a trend of alcoholic hepatitis. So this might be a case of a viral hepatitis in the background of alcoholic liver disease. So this is the pattern. And also, and this is the bilirubin elevation is one thing I want to highlight. 12 may be possibility in the case of them. So next case we'll go. The same patient has ALT and AST of 182. How do you interpret this case? So if ALT is 245 and AST, this is classically looking ALT more than AST, that is looking classically a viral hepatitis pattern. So viral hepatitis is something you see in the patient. So this is like no alcoholic, the viral hepatitis is what we see. And follow up after 6 weeks showed still the bilirubin. Let's say the patient is being treated, you advise some symptomatic hydration and all, and still the patient is still showing the bilirubin of 12 after 6 weeks. So what is the possibility? How do you treat after 6 weeks? You ask them to follow up like that. It is nothing. Viral hepatitis is there. It will be treated. So you can come back after 6 weeks. After 6 weeks, also enzymes all normal. ALT is normal, AST is normal, and everything is normal. But bilirubin is still elevated. What do you tell the patient? Still bilirubin is 12. So what happens is initially how viral hepatitis is interpreted generally initially enzymes will be elevated. ALT, AST will be elevated. Some bilirubin elevation will be there, and generally and after ALP won't be significantly elevated. But if the with the ongoing like as the days pass by, weeks pass by, ALT, AST will come down, but the bilirubin and the ALP will start elevating. They'll stay for around 6 to 8 weeks. So the bilirubin, this conjugated, this congestive, this will take time. The congestive hepatopathy will take time to resolve. So that is why after 6 weeks also the bilirubin peak generally will occur around 4 to 6 weeks in the case of viral hepatitis. So it might take time, some around 6 weeks or something. Bilirubin will be still be elevated. So that is normal. It will resolve after 2 to 3 months. It will generally resolve in the case of viral hepatitis. That is just like because of the hepatic congestion related cholestasis. It will resolve. There is nothing that needs to be done. You can add udiliv if you want to, but that doesn't need significant any treatment per se. That is normal. You can explain the patient it is normal. So after viral hepatitis, the bilirubin will be elevated for some around 6 to 8 weeks. It is usually elevated because initially there is viral hepatitis pattern, hepatocellular pattern, that will gradually converted to more of a cholestatic pattern. So that is normal, that you expect in the case of viral hepatitis. So in this patient after 6 weeks the bilirubin elevation of 12 is usually normal. It will resolve on its own. You can assure the patient that it is common after viral hepatitis. So this one. So like in this patient the bilirubin is 10. Let's say the bilirubin is 10, the ALT AST is 182. How do you tell what do you expect ALP to be? So generally ALP in the case of any hepatocellular, like in the intrahepatic cause of cholestasis, that is because of the congestion related cholestasis, ALP won't be significantly elevated. Generally it will be elevated less than 3 times. But when you go to the outside, like when there is a significant obstruction is there, some bile duct obstruction or cholelithiasis is there, some cholestatic jaundice, significant cholestatic jaundice is there where there is no significant enzyme, then ALP will be more than 3 times the normal. So in the case of viral hepatitis, generally ALP will be less than 3 times. Sometimes it goes to 3 to 5 times and all. So that is one thing I want to highlight. A 50-year-old male known case of diabetes and hypertension present with pedal edema. Then there is a tender hepatomegaly on examination. LFT showed ALT of 200, AST of 190, and bilirubin is 6 and ALP is 290. So how do you interpret this case? So this is a case of 50-year-old diabetes and hypertension present with pedal edema. So there is a tender hepatomegaly. So tender hepatomegaly is classically seen in very few conditions where there is an obstruction, veno-occlusive disease, especially any congestive hepatomegaly is there, or a congestive heart failure at hepatomegaly, or in the case of Budd-Chiari it will be there because of the veno-occlusive disease, or sometimes in the case of viral hepatitis sometimes tenderness will be there because of the excessive inflammation and all. So very few conditions will cause tender hepatomegaly. One of the most common cause of tender hepatomegaly is congestive hepatopathy secondary to congestive heart failure. So this might be case of congestive heart failure where enzyme elevation will be usually around 2 to 3 times the normal. In alcoholic hepatitis also usually 2 to 3 times the normal. In the case of viral hepatitis, sometimes it stays around 4 to 5 times the normal. It's significant. Fulminant viral hepatitis, it will goes to 1000 also. Sometimes it goes to 1000 in the case of viral hepatitis, but generally it stays around 4 to 5 times the normal. So this might be a case of congestive hepatomegaly where there will be elevation of bilirubin more than 3 or something. ALP will be elevated and enzyme elevation will be 2 to 3 times. So this might be a case of congestive hepatomegaly. You start them on diuretics and fluid restriction and treat. That's the treatment in the case of congestive hepatomegaly. So same patient has ALT of 900 and AST is 800. So the same patient with diabetes and hypertension, ALT is 900 and AST is 800. Bilirubin is 12, LDH is 700. So unlike in the previous case where ALT and AST are generally around 200 190, which is around 3 times the upper limit of normal, less than 200 and all. Here enzymes are almost touching the thousands. What is the possibility? So bilirubin is also on the higher side, LDH is also 700, but ALP might not be significantly elevated in this patient. So this might be a case of ischemic hepatitis. So ischemic hepatitis is one thing where there are very few causes that can cause enzyme elevation to thousands. One is ischemic hepatitis, the other is viral hepatitis, the other is drug-induced hepatitis. So here viral hepatitis is unlikely since the patient doesn't have any prodromal symptoms. Drug-induced hepatitis, you suspect any phosphorus poisoning or paracetamol poisoning or some mushroom poisoning or something, but that is not the history in this case. We expect ischemic hepatitis. Here ALT is 1000, they're almost touching the thousands, and bilirubin is also 12. In the case of ischemic hepatitis, ALP won't be significantly elevated. Only enzymes are elevated because it's purely hepatocellular damage. And LDH is 70. So let's say how do you, there is enzymes are in 1000, you are not sure whether it is due to ischemia or secondary to some drug or something. How do you tell whether it is properly due to ischemia related hepatitis? There is one ratio where you can do ALT to LDH ratio. If ALT to LDH ratio is less than 1.5, it is suggestive of ischemia related hepatitis. Here 900 by 700 is generally around 1.3, 1.2. It is suggestive ischemia related hepatitis. So this might be a case of ischemia related hepatitis. So in this case, so in any acute hepatitis, you start many patients on like acid-nesylmethionine you start, LOLA you start Ulidiliv. So where to start what? So generally acid-nesylmethionine is generally used in the case of alcoholic hepatitis because they are per se deficient in the methionine. So that is why you start acid-nesylmethionine in the case of alcoholic hepatitis. Where do you start L-ornithine, LOLA, L-ornithine, L-arginine? Where do you start that patient? LOLA you can prescribe in any hepatitis patient because it helps in the urea cycle and prevent the encephalopathy. So to prevent the hepatic encephalopathy, you are starting LOLA. LOLA can be started in any viral significant hepatitis patient. So you start usually with if there is gallstones or cholesterol stones, or if there is obstructive pattern, you want to excretum conjugated bilirubin or something, you can start usually. That is where you can add LOLA in the case of to prevent hepatic encephalopathy, Musam in the case especially. And Musam is generally acid-nesylmethionine is generally used in the case of alcoholic hepatitis because they are deficient in methionine. And usually we start generally in the case of there is gallstones or some obstructive pattern of jaundice is there. Generally used in the case of gallstone to dissolve the gallstones and all. A 20-year-old male present with on the routine checkup was found to have bilirubin of 3 milligrams per deciliter, which is unconjugated. So 20-year-old male, he is not having any symptoms per se, but he was found to have unconjugated bilirubin on routine checkup and all. So how do you interpret? So there are some congenital conditions where they can have hyperbilirubinemia. That can be, there are like Gilbert syndrome is there, Crigler-Nazar is there, especially in the case of unconjugated path. In the conjugated, you have Dubin-Johnson and Rota syndrome. So if there is here there is unconjugated hyperbilirubinemia, you suspect Crigler-Nazar or Gilbert. So generally Crigler-Nazar will cause type 1 and type 2. Generally will cause around 8 to 10, like more than 10 or something, a significant elevation. Type 1 will cause significant elevation of 20 or something. The patient won't survive also. Type 2 will generally have 8 to 10. But anything less than 3, it is very common. Gilbert syndrome is very common in our population. Always suspect. If the patient is coming to you with a routine report of a persistent bilirubin of 3 or something, you always suspect Gilbert syndrome in such patient. So generally nothing needs to be done. It is actually protective. Bilirubin is actually protective for cardiovascular risk. So unconjugated hyperbilirubin is generally protective. So nothing needs to be done. In some case of stress, that bilirubin might go till 6 also. But this you can reassure the patient. If you want, you can test them for UDP glucuronidase transferase, UDGA enzyme for the Gilbert syndrome pathway. This is a case of Gilbert syndrome. Case 5, 18-year-old patient presented to hospital with the complaints of jaundice and altered sensorium. On evaluation, he was found to have enzymes with ALB of 70, and neurological symptoms showed tremors and dystonia and dysmetria. So 18-year-old female, he presented with enzymes like jaundice and neurological manifestation, the of psychiatric manifestation, dystonia, dysmetria, and also as pure IQ also. So his enzyme elevation in 1000. So there is one disease that can present with your fulminant hepatitis any age, that is Wilson's. So Wilson's can present to you with acute fulminant hepatitis at any age. So this might be a case of acute liver failure. So liver failure is generally you tell when there is enzyme elevation with encephalopathy. Only enzyme elevation and bilirubin or enzyme derangement is there that can cause acute liver injury is what we call. If encephalopathy is there, then we can call it as liver failure. So here there is altered sensorium, and that's why I'm calling it acute liver failure. So this one more fulminant liver failure, this might be a case of Wilson's disease. Wilson's disease is one more that can present to you with acute liver failure, and ALP will be subnormal in this patient. ALP will be generally low because of the coenzyme deficiency. That is, the copper is generally required. Copper is generally required for them. The coenzyme, the ALP. So that is why it is low. So this is a case of Wilson's disease. How do you treat that? You generally use zinc supplementation. You can give penicillamine also. So that is how you treat this patient. So this is a case of Wilson's disease. That is how you manage, but you should start the treatment early in the phase. But after something significant decompensation has occurred, I'll discuss Wilson's in a separate topic. But like something significantly already cirrhosis has happened, there is nothing much can be done. But initial treatment can generally reverse the patient prognosis, like can prevent the cirrhosis of all this patient. If you find that there is, since the neurological manifestations are there, if you have to examine the ophthalmoscope, you will find kernicterus also, like no, Kerfish on kernicterus, Kerfisher ring, sorry, Kerfisher ring will be there. A 50-year-old elderly female on routine evaluation has elevated ALP of 800 with normal bilirubin and enzyme levels. So here 50-year-old female is there, but generally his ALP is elevated 800, but bilirubin and enzyme levels are normal. How do you suspect? So a 60-year-old female that is coming to you with ALP elevation. So what do you suspect? So ALP elevation, first you should check whether it is a liver specific ALP or some bone related ALP or intestine. Intestine related ALP generally doesn't cause significant elevation, but first thing you should suspect if there is any bone. So at this age, multiple myeloma doesn't cause ALP elevation, but other bone mets like ovarian malignancy or breast malignancy can have bone mets. So always check for that any bone specific, but you can't get a bone specific and liver specific ALP in our lab parameters. You can get a GGT done. So if GGT is also elevated, this might be a case of liver cause. If it is not elevated, it might be a bone cause. Always get a skeletal survey to look for any, like you get a X-ray skull, you get an X-ray spine and also look for the X-ray hip and pelvis if there are any lytic lesions. Like Paget's disease is also a possibility. Paget's also can cause ALP elevation. So there are many causes, like Paget's can cause, bone mets can cause, even vitamin D deficiency can cause ALP elevation, even parathyroid tumors can cause. So they all can cause ALP elevation in that patient. So there are many causes of bone related ALP elevation also, especially at this age. One is the malignancy is possibility, then Paget's can also present, then next vitamin D deficiency. Any parathyroid tumors also can present in this patient. Parathyroidenoma can cause ALP elevation. So that might be also a possibility in such cases. But in this case, if GGT is also elevated, always get a skeletal survey to look for any bone lytic lesions or any blastic lesions in the bone. X-ray skull, X-ray spine, X-ray forearm and hands for the parathyroid X-ray, because parathyroid has significant predilection to the wrist, forearm bones. That's why in the case of parathyroid or parathyroid adenoma workup, it causes significant lytic lesions in the forearm bones. That's why you get a forearm bone and a hand also. X-ray hip and pelvis also you need to get to look for any Paget's. But if let's say the patient GGT is elevated, ALP is elevated, so there are some intrahepatic causes like intrahepatic granulomas and also sarcoidosis and also even the primary biliary cirrhosis, where the extrahepatic, you won't find ultrasound will be normal in that patient, where the intrahepatic cholestasis will be there. That can cause ALP, like primary biliary cirrhosis and some sarcoid granulomas can cause. So they are also possibility. They might not have significant bilirubin elevation in them patient. Generally, primary biliary cirrhosis will cause elevation in bilirubin also, but sometimes that might not be present. So just because ALP is only elevated, that doesn't mean only bone is the cause. Sometimes intrahepatic cholestasis like granulomas and primary biliary cirrhosis will have sometimes only ALP elevation as a first manifestation. So always look for GGT also in that patient to look for any hepatic cause. If it is there, if the GGT and ALP both are elevated, then check an ultrasound to look for any bile duct dilatation or any gallstones are present or not. If the bile duct is all normal, common bile duct, everything is normal, always go for an AMA levels, anti-mitochondrial antibodies for primary biliary cirrhosis, and get a liver biopsy also, look for any granulomas and all. That can be TB or that can be sarcoid or anything. So just because only ALP elevation is there, bilirubin is elevation is not, that doesn't mean the liver is not the cause. Sometimes liver might also be a cause. So let's say hyperbilirubinemia ALP is also there. This might be a case of proper liver cause that can be due to the obstructive jaundice, that can be cholelocholithiasis or cholangiocarcinoma, that can be pancreatic carcinoma, that can be periampullary carcinoma. So always get an ultrasound to look for any biliary duct dilatation or gallstones or any mass. Get an MRCP also if required. If it is not there, go for a liver biopsy, AMA levels and ACE levels to look for the intrahepatic cholestasis. So bilirubin is conjugated and ALP is elevated, ultrasound no choletic. So in this cases, conjugated pattern is there. The ALP is elevated, ultrasound showed no cholelithiasis or duct dilatation. So you look for the intrahepatic cause, where you look for anti-mitochondrial antibodies for primary biliary cirrhosis and get a liver biopsy for any granulomas or any for sarcoidosis or TB, and also you can get an ACE levels also. So a 30-year-old female presented to OPD with LFT. LFT report. There are other causes of like progressive familial intrahepatic cholestasis is also a possibility in this case, where you'll have hyperbilirubinemia, ALP elevation, but sometimes GGT might be normal in PFIC1 and PFIC2. I'll discuss about the lateral type. There are progressive familial but this is a sudden onset. Previously, if the history is there, that might be a possibility of progressive familial intrahepatic cholestasis. That is also there. PFIC1, PFIC2 is there. I'll discuss about what is progressive familial intrahepatic cholestasis 1, type 2, type 3. So I will discuss about later, but that might also be a possible, but that is a progressive, that will be present since the 2028 also. You will find from the early in the onset, early adulthood only you will find. I'll discuss it about the later next slides, but this is the possibility. A 30-year-old female presented to OPD with the LFT report of ALP of 300 and bilirubin of 8, and this is conjugated pattern. So here ALP is elevated, bilirubin is elevated, but enzymes since they mentioned we are taking it as normal. So any female that comes to an OPD with ALP elevation and bilirubin elevation, so that is looking like a conjugate obstructive pattern is that since enzymes are normal, you are looking at the obstructive jaundice pattern. So always get an ultrasound. First you get an ultrasound, look for any gallstones which are very common in those patients. Get a ultrasound. If it is not there, always ask for the history of any OC pills. So OC pills can cause bland cholestasis without any enzyme elevation. That is made by case of bland cholestasis secondary to OC pills. Always ask for the drug history, especially when you are looking at the LFT report. Always ask for any drug history because are most common. OC pills can cause bland cholestasis. Steroids, anabolic steroids like testosterone, especially who are gym workers and all, they can have bland cholestasis secondary to testosterone and all. Testosterone can cause bland cholestasis. Even common drugs like all the anti-epileptics like phenytoin. Phenytoin can cause enzyme pattern similar to viral hepatitis. Valproate can cause alcoholic hepatitis pattern like steatosis. There will be steatosis in the lung, steatosis in the liver and all. Even nitrofurantoin can cause hepatitis or hepatitis. These are all common antibiotics with common drugs we use. Phenytoin, valproate, nitrofurantoin can cause even amoxicillin clavulanic acid that can cause hepatocellular jaundice pattern like there will be viral hepatitis not viral hepatitis, there will be hepatitis with jaundice. So they all can cause aminoclavulanic acid, clindamycin can cause, valproate can cause, phenytoin can cause, OC pills can cause, anabolic steroids can cause, carbamazepine can cause, carbamazepine can cause bile duct injury also, that can cause vanishing bile ducts. So always ask for drug history. This might be case of OC pills related to bland cholestasis pattern. A 20-year-old female using ATT now presented with a deranged LFT. AST and ALT is 200 and ALT is 300 and bilirubin of 6 and ALP. So one of the most common cause of drug-induced liver injury in our setup in India is ATT related. So ATT related injury is very common because isoniazid and rifaximin and pyralizamide are the common drugs that can cause the drug-induced liver injury. One of the most common is isoniazid. So isoniazid will generally cause what it is called hepatocellular, whereas rifampicin causes more of obstructive jaundice. So how do you tell whether it is secondary to hepatocellular or obstructive is how do you do it? R factor. R factor is done by ALT by upper limit of normal in the lab reference by divided by ALP by upper reference of normal. So if it is more, the R factor ratio is more, R factor ratio is more than 5, it suggests of hepatocellular pattern. If it is less than 2, it is suggestive of cholestatic pattern, that is more favoring rifampicin. Less than 2 is rifampicin, more than 5 is isoniazid related pattern. That is how you define it. If it is 2 to 5, more than mixed, like more isoniazid and rifampicin are causing, both are causing the injury. So here mostly it will come more than 5. So because, or sometimes it can be mixed also, I didn't calculate it, but that can be mixed to hepatocellular pattern. Maybe the isoniazid the predominant cause of this damage. So this R factor is very helpful in differentiating. More than 5 is hepatocellular. Always learn about R factor and also discriminant function scoring and Lilly scoring. So this will help you in guiding the treatment. So R factor will tell you whether it is a hepatocellular or cholestatic, but you can do it for anything. Mostly we use in the case of drug-induced liver injury, but you can do it on other patterns also, but mostly in this case. And also how do you label it as a drug-induced liver injury? So drug-induced liver injury is generally defined as anything more than 5 times the upper limit of normal liver enzymes, or more than 3 times the upper limit of normal enzymes with the symptoms, that is can be jaundice, nausea or vomiting, anything, or ALT more than 3 times the normal with the total bilirubin more than 2 milligrams per deciliter or something. So more than 3 with the symptoms, or more than 3 with bilirubin more than 2, or ALP more than 2 times the upper limit of normal. So this is the definition of drug-induced liver injury. So any enzyme elevation more than 5 times, or any enzyme elevation more than 3 times with the symptoms, or total bilirubin more than 2, or ALP more than 2 times the upper limit of normal is the definition of drug-induced liver injury. So this is fitting into the case of drug-induced liver injury. We calculated R factor, which is suggestive of more than hepatocellular factor or mixed pattern. So this might be case of ATT-induced liver injury. You need to stop the drugs and restart the therapy. You can start in between. You can start levofloxacin, streptomycin, ethambutol therapy in between. So how do you restart the ATT in the patient with liver injury? I will discuss in the again topic in the case of ATT-induced liver injury. But read about it is very interesting. There are many articles from the BMG and also American Thoracic Society guidelines. So and also WHO guidelines also there for the how do you reinitiate the ATT in the case of drug-induced liver injury. Read about it. I'll also discuss it in the later chapters. So this might be case of isoniazid related or mixed pattern in the case of injury. A 14-year-old male on anticonvulsant now present with a fever, rash and has LFT showed elevated ALT and AST in 400 with ALP of 200. So he's on anticonvulsants. We don't know what is the anticonvulsants per se. He has fever and rash, and as LFT showing ALT and AST in 400. There is enzyme elevation pattern, and ALP is also elevation, but mostly looking like hepatocellular because ALP is not significantly elevated. So generally in the case of hepatocellular pattern, ALP will be elevated, but not more than 3 times or 4 times. If it is purely obstructive pattern, ALP will be like cholestatic pattern, it will be more than 3 times, more than 3 to 4 times, it will go till 10 times also sometimes. So this morely because in a cholestatic pattern, enzyme pattern won't be significant elevated. Like generally it will be less than 2 to 3 times the normal. Here it is more than 3 times the normal. There is morely looking at hepatocellular pattern. So what is the cause? There is also fever and rash. So there are certain drugs. So certain drugs like phenytoin and also dapsone, sulfonamide drugs, they can cause DRESS syndrome. So DRESS syndrome is a drug related that can cause fever, rash, eosinophilia, and also lymphadenopathy, liver injury. These are all part of DRESS syndrome. So this might be a case of DRESS syndrome. One anticonvulsant that can cause DRESS syndrome is phenytoin. So phenytoin can present. It can present at any age. So drug-induced liver injuries can occur at two types. One is direct drug injury, like the direct paracetamol poisoning or phosphorus poisoning or mushroom toxicity. They all can directly cause liver injury directly because of their metabolites. So if you take paracetamol or mushrooms or phosphorus, no, within 2 to 3 days you will definitely get liver injury in the toxic dose. In the toxic dose you get directly. That is because of the drug and metabolite of this whatever poison we are consuming. Because of that you will definitely get liver injury. But there are some other drugs which are idiosyncratic. You don't know when they will occur. So that can be the idiosyncratic, like example isoniazid. Isoniazid is idiosyncratic. So you don't know, like if you start the drug today, maybe 2 months later or 3 months later or 6 months later or 1 year later you will get the reaction. You don't know when it will occur. One such drug is phenytoin. So phenytoin, these are all called idiosyncratic. Phenytoin, valproate, they're all idiosyncratic. You don't know when they will occur also. And mostly they'll occur subtly and adopt, like because after starting valproate or phenytoin you'll have some mild elevation, but they will subside, they will adopt, liver will adopt, and the enzymes will come down again. So these are idiosyncratic. You don't know when they will occur. Like example isoniazid, phenytoin, valproate. So there are many examples. Most of them are idiosyncratic. So one such example is phenytoin. So these are idiosyncratic reaction. You don't know when they will occur. It can occur at any time during their lifetime. So I mean they started on drugs. So one such drug is idiosyncratic reaction where they can cause a DRESS syndrome. Like syndrome are mainly sulfonamides and phenytoin. So this is a DRESS syndrome. You start them on steroids. So this is immune mediated reaction. So immune mediated related liver damage and also systemic immunity is the cause. So you start them on steroid. This might be a case of phenytoin related idiosyncratic liver injury with the DRESS syndrome. So this is we ended at the topics and all. We ended the case discussion. We discussed about alcoholic hepatitis. You discussed. Let's say the patient is not alcoholic. One of the most pattern you'll find AST, like ALT more than AST. You're not finding any cause, but there is fatty liver in the background. Like let's say a type 2 50-year-old type 2 diabetes patient with hypertension who is little obese, and you found ultrasound showed a grade 2 fatty liver and all. An enzyme pattern showed AST of 300 and ALT of 200 or something. So it's sorry, ALT of 300 and AST of 200 or something. So you can suspect NASH. NASH is very common in our present. Non-alcoholic steatohepatitis or metabolic syndrome associated steatohepatitis is very common in our present day setup. So NASH is the most common presentation. If you are not finding, like it is not looking alcoholic, patient does not have significant alcoholic in history, but ALT is more elevated than AST. There is fatty liver. Patient has comorbidities, deranged liver profile is there, hypertension is there, diabetes is there, waist circumference is more. You are not finding any cause. No viral hepatitis, no Wilson's disease, no ischemia, no congestive hepatopathy, no drug usage. Always think of non-alcoholic steatohepatitis. So NASH is also a possibility. NASH is very common. It's more common than many other diagnoses like viral hepatitis or alcoholic steatohepatitis, which is in the present set of non-alcoholic steatohepatitis is very common. So that is coming to the end of all the discussion. We'll discuss R factor. I tell you ALT by upper limit of normal divided by ALP by upper limit of normal. So if it is more than 5, you can suspect the hepatocellular causes like viral hepatitis or autoimmune hepatitis. One more thing I forgot to discuss. Any patient that is coming in, a 20-year-old female that is having history of ALT AST elevation with not significant ALP elevation, sometimes they will be there, but more of hepatocellular pattern is always suspect autoimmune hepatitis, especially in the background of ANA positivity. Always send an ANA. With you are not finding any cause like viral hepatitis is not there, and also you are not finding any alcohol history also, especially young females 20s are also, especially autoimmune hepatitis type 2 will present around 20s and all, but type 1 present at 20s and all. Type 2 will present at little childhood only, like around 12 13 only they will present. Always send ANA in them. So you can start them on steroids. ANA will be generally be positive. If it is not positive also, there is autoimmune hepatitis panel. I'll discuss about autoimmune hepatitis separately. There is LKM antibody and anti-liver cytosol 1 is there. You can send them also. But always any young female that is coming to you with a viral hepatitis, like hepatitis pattern with 200 300 enzymes with mild elevation of LP and bilirubin, you are not finding any cause of viral hepatitis or any other possibilities are not there, drug is not a possibility, always suspect autoimmune hepatitis also in these patients. So always ask for any other autoimmune conditions are present, send an ANA. If high suspicion is there, always send for a biopsy and other anti-liver antibodies profile also. So that autoimmune hepatitis is also a possibility. You can start them on steroid. They'll have a, like, they won't go into cirrhosis. If you don't treat them, they'll have recurrent jaundice. Main common complaint of the autoimmune hepatitis is recurrent jaundice, recurrent hepatitis will be there. You'll have significant history. Like previously also they'll be admitted with hepatitis or jaundice pattern. You can ask them. Recurrent jaundice is one more presentation of autoimmune hepatitis. So this autoimmune hepatitis is a hepatocellular pattern, generally hepatocellular pattern. And also you can ask for a lot of hepatitis serologies for all hepatitis A, hepatitis E, hepatitis B, hepatitis C. EBV, CMV also can cause viral hepatitis. You generally stop, most of us stop at hepatitis A, B, C, E are the more common serologies we do. But EBV, CMV can also cause viral hepatitis. They are also hepatotropic viruses only. They allow fever, lymphadenopathy and hepatosplenomegaly manifestations. So always make it as a habit, you do EBV, CMV also in hepatitis panel. So because these are normal, hepatitis A, B are normal, you tell there is no viral hepatitis. EBV, CMV are also common. IgM is significant, IgG is not significant. IgM is what you take significant. If there is cholestatic pattern, first get an ultrasound done. If you look for any biliary dilatation or gallstones are present, then get an MRCP or ERCP. If it is still not there, no duct dilatation or there, you can go for AMA levels and liver biopsy. Mixed, you can need to work up for both. So this is how you examine. First you ask for the physical examination. So you get a bilirubin level and ALT and AST and alkaline phospholase and prothrombin and albumin. If there is only isolated elevation of bilirubin, first check for direct bilirubin is there. Direct bilirubin, anything more than 15% of total bilirubin is there, that is direct hyperbilirubinemia. If there is no enzyme elevation, there is no ALP elevation, always look for the inherited Dubin-Johnson and Rotar syndrome. So these are the possibility, Dubin-Johnson and Rotar syndrome. If there is no, only bilirubin, hyperbilirubinemia is there, ALP is normal, ALT is normal, AST is normal, always look up Dubin-Johnson and Rotars. If the pattern is not indirect hyper, there is indirect hyperbilirubinemia is there, direct is less than 15%. As I told you, once you should ask for drug history like rifampicin or probenecid. Rifampicin can cause indirect hyperbilirubinemia. And also Gilbert and Crigler-Nazar syndrome. So they're congenital, inherited conditions like Gilbert and Crigler-Nazar syndrome. Gilbert will generally around 3 or something, Crigler-Nazar will be 8 to 10 or something. So other hemolytic. So any isolated hyperbilirubinemia, only bilirubin is elevated without any ALP and AST elevation. One thing you check for direct bilirubin. Direct bilirubin is more than 15%. Dubin-Johnson and Rotars are the possibility. If it is less than, direct bilirubin is less than 50%, it is more going in the favor of unconjugated hyperbilirubinemia. First check for hemolytic joanemia. LDH, any LDH is elevated, any autoimmunity is there. So you need check for any hemolytic anemia is there. Then you check for any drugs like rifampicin usage is there. Then you check for Gilbert's and Crigler-Nazar syndrome. So this is the pattern, hyperbilirubinemia. Let's say the patient is having bilirubin with other altered liver enzymes are also a possibility. Let's say ALT and elevated, AST elevated, like hepatocellular pattern, where ALT and AST are more elevated when compared to ALP. So like for viral serologies like hepatitis A, B, C, CMV, EBV, and any toxin intake like paracetamol poisoning or something, or ceruloplasmin also, especially if less than 40 years or something, ceruloplasmin, and also ANA. So ANA is all, ANA, SMA are all liver and autoimmune hepatitis panel. So this all needs to be done. If needed, always get a CMV and EBV also, hepatitis A, B also. If still not finding any cause, go for liver biopsy. If let's say ALP is more elevated when compared to AST and ALT, get an ultrasound. So ultrasound is suggestive of dilated ducts or extrahepatic cholestasis. Always get an MRCP or ERCP. That is the best thing that can be done. Let's say ducts are not dilated. So that is intrahepatic cholestasis that can be due to AMA, that is antimitochondrial antibody secondary to primary biliary cirrhosis. Because primary sclerosing cholangitis affects both intrahepatic and extrahepatic bile ducts. So that will be found in the case of ERCP or MRCP. But let's say only intrahepatic is there, antimitochondrial antibody is one possibility. And again, viral hepatitis can cause intrahepatic cholestasis, alcohol can cause intrahepatic cholestasis, that is also a possibility. So always get a serology also done, because in the late phases of that, in the late phases of viral hepatitis, in the after 4 to 6 weeks, the enzymes will come down, only cholestatic pattern will be there. So that is why always get a serology done. So that sometimes viral hepatitis can present as cholestatic in the late after late stages of disease. So always get a repeat viral hepatitis serology also. If they're all negative, always get a liver biopsy. So liver biopsy is one thing that will tell you about whether granulomas are there or some intrahepatic duct damage is there, that can be secondary to some drugs are there. Especially like carbamazepine can cause vanishing bile duct syndrome. So some drugs can cause granulomas, like carbamazepine can cause granulomas. So always look for the drug history. Some drugs can cause intrahepatic cholestasis. So always look for them also, and liver biopsies will tell you more about what kind is a possibility. So these are the causes of isolated hyperbilirubinemia, indirect hemolytic ineffective erythropoiesis. Any massive blood transfusion also can cause. Any hematoma resolution, especially if there is a extradural hematoma, extradural or intradural hematoma is there. During the resorption phase, some amount of bilirubin will be there because of the metabolism of hematoma. So drugs like rifampicin, antibiotics like cephalosporin, penicillin can cause isolated hyperbilirubinemia, especially indirect. So indirect, always look for all these causes. These are important. Like resorption of hematoma is one thing you miss. Like the patient presenting you with a subdural hematoma or extradural hematoma, after some days you will find some bilirubin elevation. You started working up for alcoholic hepatitis and something else. So always some hematoma might be a possibility. Generally, it will be less than 3 or 4. That are not significantly elevated and all. And antibiotics. The antibiotics you use like rifampicin or cephalosporin, they can cause hyperbilirubinemia. Always look for them. Indirect hyperbilirubinemia is possible in them. If direct hyperbilirubinemia is there, Gibbon Johnson and Rotars are a possibility. Hepatocellular condition that can cause hepatitis can cause alcoholic hepatitis, can cause jaundice, chronic liver disease can cause jaundice, and acetaminophen can cause jaundice, and toxins can cause jaundice. Even mushroom poisoning can cause Wilson's disease, autoimmune hepatitis. Though they're predominantly hepatocellular pattern, they can also cause jaundice. They can also cause mild amount of jaundice, like around 8 to 10 jaundice, because of the intrahepatic cholesterol can be possible. But ALP won't be significantly elevated. That is how you tell. So that is whether obstructive or not, based on the, say, ALP won't be ALP will be significantly elevated in the case of obstructive jaundice, not extrahepatic cause. ALP will be significantly elevated. So these are the cholestatic causes of jaundice, like intrahepatic cause like viral hepatitis, like fibrostatic cholestatic, like hepatitis B and C. Hepatitis A can cause alcoholic, like I mentioned you that like even hepatocellular causes can cause jaundice, like alcoholic hepatitis, a drug. It's like drugs, pure cholestasis then can be like anabolic steroids and contraceptives. OCPs can cause pure bilirubin elevation and ALP elevation without any ALT and AST elevation. That can also be a possibility. Cholestatic jaundice like chlorpromazine, erythromycin can cause, and primary biliary cirrhosis, primary sclerosing cholangitis, especially more of cholestatic pattern, that is more of ALP and bilirubin elevation, and vanishing bile duct syndrome. So in them, the enzyme elevation won't be significant, though they are intrahepatic. Like in the case of primary biliary cirrhosis, though they are intrahepatic, ALT and AST won't be significantly elevated. So that is one thing that will tell you. So primary biliary cholangitis is the thing where the intrahepatic cholestasis will be there, where the intrahepatic bile ducts will be damaged, where there won't be any ALT elevation, only ALP elevation and bilirubin elevation will be there. But if they, let's say there is hepatocellular causes there, like they can also cause jaundice because of some amount of intrahepatic cholestasis in them. ALT will be predominant cause. So it depends on the damage of the bile ducts. If the bile ducts are significantly damaged, that will cause more of ALP and bilirubin elevation. If the cells are the more cause of damage, that will cause more enzyme elevation. So that will tell you whether intrahepatic cholestasis is secondary to hepatocellular damage or bile duct damage. So in the vanishing bile ducts and syndrome, that can be secondary to rejections and sarcoidosis, and some drugs like carbamazepine can cause vanishing bile ducts. So congestionopathy can cause intrahepatic cholestasis because of the congestion. In them, the enzyme elevation will be more, and that will cause the congestion, and that can cause bile duct damage. But whereas in the case of primary sclerosing cholangitis, primary biliary cholangitis, and vanishing bile duct, here the biliary causes the main damage, where the bilirubin and ALP will be more significant always. Cholestasis of pregnancy, and paraneoplastic causes, veno-occlusive diseases, like we mentioned in the case of Budd-Chiari syndrome and all. And graft versus host disease also can cause intrahepatic cholestasis. So that is also a positive. In the veno-occlusive disease is positive after bone marrow transplant because of the drugs we use, melphalan, they can also cause the veno-occlusive disease. So infiltrative disease, lymphoma, tuberculosis, and also infection, malaria, they're all causes of the cholestatic jaundice that can be caused intrahepatic, some because of the congestion of liver inflammation and all. Extrahepatic can be cholangiocarcinoma, pancreatitis. This can easily be found, like benign, like choledocholitis, primary biliary, primary sclerosing cholangitis, AIDS cholangiopathy, Miras's syndrome due to compression of bile duct, and parasitic causes, because they can be extrahepatic causes, can be easily tell. In them, the significant, like sometimes ALT will be elevated, but more significant ALP and bilirubin elevation will be there. Bilirubin will be around 10, 15, down 20s also sometimes. So these are the various liver pattern tests you generally see. In Gilbert syndrome, generally ALT, AST all will be normal. Only mild bilirubin elevation around less than 3 will be there. Acute hepatocellular necrosis, that viral or ischemic or drug induced. AST ALT will be generally more than 500. Generally ALT will be more than AST in the case of more of acute hepatocellular. Generally ALP will be less than 3 times hepatocellular pattern. So they can cause jaundice. Usually jaundice can also be a possibility in them. Generally both fraction. Generally peak of bilirubin elevation will generally follow aminotransfer. First enzymes will be elevated, then jaundice. That is also will tell you whether hepatocellular pattern or not. First enzymes will be elevated, then bilirubin will be elevated. So that is there. So generally enzymes will be elevated. ALP generally less than 3 times. As I told you in the most of the hepatocellular pattern, ALP will be less than 3 times upper limit of normal. Albumin will be normal. Prothrombin time usually normal. Sometimes can be elevated in the case of very bad prognosis. very fulminant liver failure or something. In the case of chronic hepatocellular condition, generally both fractions of bilirubin elevated because of the decreased conjugation defect and decreased excretion defect also. Generally, in the case of chronic liver disease, generally enzymes will be less than 300, not more than that, because cells are already damaged. ALP also will be less than 3 times. Generally, albumin will be decreased and prothrombin will be prolonged because there is already chronic liver disease is there. So significantly synthetic function is affected. So generally albumin will definitely be decreased and synthetic function will also be affected. So how do you tell whether the chronic hepatocellular is due to the hepatocellular? Generally, prothrombin time won't be corrected with vitamin K in the case of hepatocellular disorders like any chronic liver disease there. Even though you give vitamin K, there is no point because it won't correct. Prothrombin time won't be corrected even if you give vitamin K in the case of chronic liver disease. So that is one thing that will tell you, guide you whether it is a chronic liver disease or chronic hepatocellular disorder is there. And also even acute hepatocellular also not corrected by parental vitamin K. So there is no point of giving vitamin K in those patients who are having hepatocellular cause of the prothrombin elevation, because in DIC you might try, but generally there is no point of giving in hepatocellular because it won't correct because the cells are itself are damaged. So they fail to correct with parental vitamin K, that one. Even alcoholic hepatitis, generally bilirubin might be elevated, but ALT and AST, this ratio will help you. AST by ALT ratio is suggestive of alcoholic hepatitis or cirrhosis. Generally, ALP will be less than 3 times the limit of normal. Albumin will be decreased because of the decreased per se poor nutrition and all. Generally, this is also generally PT will be prolonged and cirrhosis, like in the case of severe alcoholic hepatitis, PT will be prolonged and prothrombin time will be prolonged and fails to correct with vitamin K. So all the case of hepatocellular like hepatitis, alcoholic hepatitis or anything, it fails to correct with vitamin K. And one more thing, alcoholic hepatitis itself can cause portal hypertension because of the functional inflammation. Viral hepatitis can cause some amount of portal hypertension because of the functional resistance, because of there is some amount of inflammation that occludes, that cause functional obstruction of the portal vein and all, that can cause portal hypertension, that sometimes can cause varices, like not varices per se, ascites also. Varices won't because sometimes alcoholic hepatitis can cause ascites also, and intrahepatic and extrahepatic cholestasis. So this can be elevated, but aminotransferase are generally less than 500. Generally won't be elevated. In the case of intrahepatic and extrahepatic cholestasis, generally won't be significantly elevated. Generally, usually less than 500. But alkaline phosphate is something which is elevated more than 4 times. If it is cholestatic pattern is there, like obstructive pattern, ALP will be more significantly elevated when compared to the ALT levels. So whether you tell the hepatocellular is the primary cause, like viral hepatitis is the primary cause, or like in the viral hepatitis initially enzymes will be elevated, later the ALP and bilirubin will be elevated. So different phases will be there. So initial phase is the hepatocellular phase, next phase is the intrahepatic cholestasis of viral hepatitis. So this might be case. In the case of extracholestasis, enzymes won't be significant, and generally around 2 to 3 times will be there, and ALP will be significantly elevated. Generally, albumin and prothrombin times are generally normal. In the case, even if prolonged in the case of prothrombin time, this will correct. This obstructive jaundice will correct because the problem is in the outside of the liver. So in the case of extrahepatic jaundice, the prothrombin will be corrected in the case of parental vitamin K. So this is one thing that will help you differentiate hepatocellular and obstructive jaundice. Infiltrative tumors and granulomas. So these generally bilirubin will be normal in them. Also transferase will be normal. Only ALP will be elevated. So infiltrators like tumors and granulomas, most of the times, as I told you in the first case, where only ALP is elevated, bilirubin is normal. Though you think of bone first, always think of liver also, because sometimes granulomas and tumors won't have bilirubin elevation, no enzyme elevation, only ALP elevated. So in them, only ALP elevation, though only ALP is elevated, first get a GGT done. So that will tell you it is liver is the cause or not. So if liver is not the cause, then think about the bone causes, like you get a skeletal survey. If GGT is elevated, then always look for any tumors or granulomas are there. Always get a liver biopsy. So this is one thing I want to highlight. So this is Crigler-Nazar. Crigler-Nazar is usually this is the case of type 1 and type 2. So generally Gilbert is something mild deficiency. Generally type 1 will have more than 20 milligrams per deciliter, 20, and type 2 will have less than 20. And type 1 is generally don't survive, they'll kept under phototherapy, they have prolonged jaundice and all, carnitris will be there. So they generally won't have any activity of UDP glucuronidase transferase. Type 2, some amount of activity will be there. You can treat them with phenobarbital. Phenobarbital is something you can use. And generally in the case of Gilbert's, they are generally asymptomatic. Generally around 3 will be there, less than 4 or something will be there. So UDP glucuronidase transferase activity will tell you what kind of classification, what kind of they fit in. Mostly you will see in the day-to-day practice Gilbert or Crigler-Nazar. Based on the bilirubin level you can tell. Generally it will be 4. It will be around 10 or 15 or something will be there. They can be treated phenobarbital. Nothing needs to be done. These generally won't survive also. Yes, per se, first thing we'll think about bile excretion. There are few problems. Like in the case of Dubin-Johnson's and Rotas, you will have bilirubin elevation. Mild conjugate hyperbilirubinemia will be there. And pigmented liver will be there in Dubin-Johnson's. You can see D for dark liver in the case of Dubin-Johnson's. Rotars is normal liver will be there. Dubin-Johnson's is due to the MRP, whereas Rotars is due to the organic anion transporter. Rotars you can say why O's are there now, Rotars organic anion transporter. So there are other causes where the bile acid excretion, where the bile acids is not what we in general measure, we measure bilirubin, but bile acid metabolism is a problem in few cases where the bile acids are the problem. PFIC type 1, progressive familial intrahepatic cholestasis type 1, type 2 and type 3 are there. And the benign variants of them are BRIC1 and BRIC2, benign recurrent intrahepatic cholestasis. If they're episodic, you call it benign recurrent intrahepatic cholestasis type 1 and type 2. If they're progressive per se, let's say they're always present, that is progressive familial intrahepatic cholestasis. So in the case of PFIC type 1, the type deficiency is ATP8B1 mutation. So in them, severe cholestasis, significant cholestasis will be there, bile acids will be elevated since the childhood. They have other pancreatitis and diarrheal manifestations also, and it is progressive nature. Let's say if the patient has only episodic elevation of bilirubin elevation, not says progressive nature is there, that is recurrent episodes of cholestasis is there, bilirubin and bile acid elevation is there, that is called BRIC type 1, that is more benign nature. The same thing is PFIC2. PFIC2 is due to the deficiency of ABCB11 mutation. So severe cholestasis in childhood, but they have higher risk of hepatocellular malignancy. So they have higher malignancy risk when compared to them. In all of them, in this both GGT will be normal. Gamma glutathione transferase will be normal, though there is a cholestatic pattern. The GGT will be normal in this patient. So the severe cholestasis in childhood, they have associated hepatocellular malignancy is a possibility in the case of PFIC type 2. In the same way, if a recurrent episodic nature is that, it's called BRIC type 2, which is more benign nature. PFIC3 is one thing which is due to the which have more GGT elevation and bile acid elevation is there, that is due to the ABCB4 mutation. So severe cholestasis in childhood, and that is they have both GGT elevation and bilirubin. And there's a very rare genetic disorder. If you want to make a video on what is the biliary canalic, how the bile canalicular excretion will occur, I'll make a separate video. That is a very big topic where bile acids and all, that is very big. I'll make a separate video on them. So these are the differential diagnosis of jaundice and all. That is hemolytic, where jaundice mainly unconjugated hyperbilirubinemia will be there. Urine bilirubin will be absent. Urinary bilirubin will be urobilinogen will be increased. Hemolytic anemia. So the main problem will always occur in the case in them. Enzyme elevation won't be significant. ALP enzyme elevation won't be there. Only unconjugated hyperbilirubinemia will be there. The main problem will occur in the case of hepatocellular and obstructive jaundice. So hepatocellular and jaundice more will be the ALT and AST elevation, and also bilirubin will be unconjugated hyperbilirubinemia. Generally, direct bilirubin will be more than 15%, but let's say conjugated bilirubin is more than 50%, is more favoring the obstructive jaundice. So this will be around 15 to 50% will be there in the hepatocellular pattern. And generally, one more thing that will tell you is urinary urobilinogen. So urinary urobilinogen, how will it occur? After going into the intestine because of absorption of the bilirubin and all. So that will be that unconjugated bilirubin which is absorbed again from the intestine will be secreted as urobilinogen. If per se bilirubin is not per se secreted in the intestine because of obstruction, how will urobilinogen will come? So urobilinogen will be generally decreased in the case of obstructive jaundice. So that is one thing you can do. You can get a urine urobilinogen and will tell you whether it is hepatocellular obstruction pattern. So urinary urobilinogen will tell you will be decreased or absent in the case of obstructive jaundice. So here ALT and AST pattern will be more in the case of hepatocellular jaundice, whereas ALP elevation will be more. Like ALT and AST elevation will be more, and ALP elevation will be more than 3 times in the case of obstructive jaundice. And correction with prothrombin. Prothrombin will not be corrected with vitamin K, where it will be corrected with vitamin K in the case of obstructive jaundice. So let's look at this page. Total bilirubin is 20, direct is 10.2, OT is 360, LP is 192. So here bilirubin is 20, definitely direct pattern more than 15%, even 50%, almost touching 50%. So here you think obstructive jaundice is a possibility, but OT is 360, ALP is 192. So OT is more than almost 5 to 6 times the normal limit. ALP is hardly more than 1.5 times the normal limit. So I think this is favoring a hepatocellular jaundice. That might be hepatocyte, viral hepatitis, or something that is transiting to the cholestatic pattern. Like initial part of viral hepatitis is more of enzyme elevation, then converting to the bilirubin elevation. So this might be viral hepatitis. This might be case of viral hepatitis, hepatocellular pattern, more favoring hepatocellular. That might be converted to the cholestatic pattern. Might be a possibility of viral hepatitis is a possibility in this case. So these are the various causes of cholestasis, as we mentioned, intrahepatic and extrahepatic causes already we discussed. So these are the various drugs that can cause, like anabolic steroids, antibiotics like erythromycin, convulsants like carbamazepine, even clopidogrel can cause cholestasis, like methimazole can cause, nifedipine, verapamil can cause. And coming to the fatty liver, like alcoholic fatty liver, like amiodarone can cause. Amiodarone can cause chronic liver failure also. Chronic liver disease can present with amiodarone. That can cause fatty deposition. Like amiodarone, exactly like alcohol. Alcoholic pattern only will follow. Amiodarone, alcohol, A. Remember that. Like tetracycline can cause, valproate can cause fatty liver. So these are all drugs you need to ask for in the case of them. In the case of hepatitis, like all the anesthetic drugs like isoflurane, methophen, isoniazid can cause, rifampicin can cause, phenytoin can cause, ketoconazole can cause, zidovin anti-ART drugs can cause. Um, there are drugs like mixed pattern like aminoclavulanic acid can cause, clindamycin can cause. Necrosis can be seen in the acetaminophen, yellow phosphorus, amentia, mushroom poisoning and all. Granulomas can be formed with sulfonamide, carbamazepine, phenylbutazone, allopurinol. This is an important NEET assess question. Granulomas, quinidine, sulfonamides, carbamazepine, phenylbutazone, allopurinol. Vascular injury can be seen with like veno-occlusive disease or something, oxyplatin and melphalan. So these are the possibilities. All that these are hepatocellular cholestasis and ductal aggregation, again mentioning the same thing. So this is the ratio I mentioned. In the case of significant ALT more than 10 times, like thousands are there. How do you tell whether it is ischemic hepatitis or some related to drug or viral hepatitis? This ratio. ALT by LDH ratio of less than 1.5 helpful in distinguishing the ischemic injury from other causes of acute hepatitis. So this is one more thing I want to tell. Thank you.